nice to have Dr. Gary Holland with us as our first guest.
Thank you.
If you spend any time in a uveitis clinic, you already know his name. And if you haven't, here's the thing you need to understand about Gary Holland. When the AIDS epidemic swept through the country in the 1980s and 90s, and young men were going blind from a virus eating away at their retinas, somebody had to be in the room. Somebody had to take a look and document and remember. Gary Holland was that somebody. He didn't just treat cytomegalovirus retinitis, he chronicled it. His 2-part study of untreated AIDS-related CMV retinitis drew a line straight through the arrival of antiretroviral therapy, what the disease looked like before the drugs that changed everything and what it looked like after. And in 2008, he stepped back and wrote the history itself, AIDS and Ophthalmology, the first quarter century. When we talk about an era that a generation of ophthalmologists lived through, his is the work we reach for. But that's only one chapter. He is, by most accounts, the world's authority on ocular toxoplasmosis. And not just from the desk. He's chased outbreaks in Brazil and in India, gone to the villages, to the water sources, to the place where it happened. And today, he's running clinical trials on something most uveitis specialists never touch, teaching medical students how to counsel patients on firearm safety. So this is a career that refuses to sit still. A clinician, a scientist, a historian of his own field, and it turns out, a person with passions that reach well past the eye. He trained right here at the Proctor Foundation, back when it was on Kirkham Avenue. Today he's back in San Francisco, and we get to sit down with him. Dr. Gary Holland, welcome.
Thank you. Thank you, Dr. Gonzales.
And
Dr. Acharya.
I'm happy to be here. You know, we're so excited to have you visit today, and you gave a really excellent Robert Nozik lecture, and Robert Nozik was present. You know, he's 92, and
I didn't realize that.
Yeah, and I don't know, had you seen him since your training?
I hadn't seen him in years.
Mm-hmm.
I saw him since fellowship, but not recently. He still looks great. He's still sharp. And as I said this morning, I have drawn upon the things that he taught me throughout my career.
Yeah, you did a great job of involving and showing his impact. We really enjoyed the lecture.
Yeah, that was great.
Thank you.
But before we get into kind of some of the history and some of your work, for our listeners, I was curious, where you grew up, how you got interested in medicine, and then ultimately ophthalmology.
I grew up in Long Beach. Until the very end of high school, I had no thought about being a physician. I was going to be an architect.
Oh, wow.
And a lot of my friends were planning on being pre-med majors in college, and I wondered what I was missing. So the summer after high school, I got a job in a hospital, which I absolutely loved. I gave up my scholarships to college. I went to Long Beach City College for a year just because it was too late to reapply.
You received scholarships for architecture?
Yes.
Wow.
And
incredible.
That summer, I loved the job I had. I was working in a pathology laboratory.
Oh, yeah.
And so actually, throughout college, I sort of thought I would become a pathologist. And then in medical school, I found that I really did not like anatomic pathology. I liked clinical pathology, hematology and bacteriology. And so throughout medical school, I knew I wanted to go to medical. I knew I wanted to be a physician, but I wasn't sure what specialty I wanted to go into until my ophthalmology rotation, and I was 100% sure then.
What do you think it was about ophthalmology that made up your mind?
The precision, the detail orientation of the specialty. I always tell our students that you have to know what kind of person you are. And if you're detail-oriented or interested in precision, if you like to sit and think about problems, ophthalmology would be good for you.
Yeah.
I would not be a good ER doc, for example. But on top of that, vision was like magic. And the combination of just the procedures that were being done, the diseases that were being seen, and I was always interested in infectious disease. And so I enjoyed seeing cases of ocular infections. And then just the idea that vision was so hard to understand and so mysterious that it's just that combination that decided it for me.
And then you did a fellowship at Emory for cornea.
Correct.
And then why another fellowship at the Proctor Foundation?
Well, I did the Proctor Foundation first.
I see.
Back in that era, actually, they wouldn't accept you into the fellowship here unless you were going to do something second year.
I think I remember.
Yes, I think it used to be that way here and at some other programs where it really was a 2-year commitment.
And a lot of the fellows would end up being a chief resident somewhere. That was an era where a lot of departments had, individual chief residents as an extra year. And then in my residency, I really enjoyed corneal surgery more than other surgical subspecialties. Okay. And also in that era, just as at the Proctor Foundation, uveitis was being managed by cornea specialists, whereas in these days, a lot of people do uveitis and retina rather than cornea.
Interesting.
And so it was just a natural combination. Plus, the person that I really considered my main mentor in residency, Tom Pettit, he had been a Proctor Fellow here at the foundation. And so he was kind of my role model. And so I decided to do cornea as a second fellowship.
Yeah, I find that really interesting. And I think that was really the case at the time that was the combination. That was very much, what a lot of people gravitated to when they did uveitis. What made you interested in coming here to the Proctor Foundation? That I know you had the contact in your residency.
I think more than anything, it was the contact.
Okay.
But also the fact that it was infectious disease oriented. And since college, I had been interested in infectious disease, became even more interested in medical school. And so it seemed like a natural.
I'm so curious. Can you share a little bit about what your fellowship here was like at Proctor?
It was a great year. And I worked with a lot of different faculty members, none of whom are still here, but besides Bob Nozik, Richard O'Connor was the director at the time, Chandler Dawson, Bruce Osler, Mitch Friedlander. I had less contact with Devon Sharp, but he was here.
That's right.
And Phil Tygeson came up once a week to talk a lot about history, which I found fascinating. And so I'm trying to think, there was 3 first-year fellows, there was a second-year fellow, and there was a number of international fellows. And each of us had a main project, and I actually was working on 2 projects. I worked on toxoplasmosis project with Dr. O'Connor and a herpes simplex project with Dr. Dawson. But the other fellows worked with other faculty. But we all worked together on, we would have weekly cornea rounds and we'd have weekly uveitis teaching rounds.
Okay.
We would go across the street to a clinic with the residents. That was our service, was to help the residents with a clinic once a week. And that's still very common in fellowships where there's some payback to the department. I don't know. It was just a great group.
What year was this, more or less?
83, 84.
Okay.
Yeah.
So 83, 84, you then go off to Emory.
Correct.
Then you go back to Los Angeles.
Yes.
And this presumably is when the AIDS epidemic is starting and patients are arriving with CMV retinitis?
It was actually when I was a first-year resident.
Oh, wow.
At UCLA. And I've told this story before, but on my pathology rotation, which we had a dedicated pathology rotation, one of my co-residents was Carl Camrus, who people may have heard his name. He basically thought up latanoprost as he came up with the idea that prostaglandin analogs could be used to treat glaucoma. So Carl and I were in the pathology lab, and at that time, all autopsies had ophthalmic examinations. So the eyes were nucleated, and so we sectioned every autopsy eye.
Oh, wow.
And so I opened an eye, and there was something wrong with the retina.
Wow.
And I had, in our basic science course, the residents gave lectures. They were assigned a topic, but you could choose what specifically you wanted to go over. So I was assigned to the retina section. And in my naivete, I said, I want to talk about viral infections of the retina, not knowing that there really were none. None, no.
Oh my goodness. That's really...
So, there were a few things, like there was rubella retinopathy that we mentioned this morning. ARN had not yet been described as being herpetic retinitis. And in my reading, I read about CMV retinitis. And so I included it in my lecture. No one on the faculty had ever seen a case.
That's incredible.
I had to take a picture out of a book. And I remember that, so this is first year, I remember the third year residents coming up to me and say, you just wasted our time because you're never going to see a case of that for the rest of your career.
Wow.
There maybe been 30 cases in the literature. They were all newborns with cytomegalic disease or organ transplant patients, most of whom were kidney transplant patients in those days. So it was just a month later that I opened that eye up, found CMV retinitis. And so I knew that it was not a baby. And I just, out of curiosity, I ordered the medical records for that patient when we were preparing the autopsy report, and there was no mention of organ transplantation. So I had been an internal medicine intern at UCLA before the internships were incorporated into residencies.
Yes.
So I did a straight medicine internship. And so I knew the Department of Medicine faculty. And a few days after this, the whole immunology team descended on the path lab and asked me what's going on. Why had I been reviewing this patient's medical records? And I said, it's CMV retinitis, and I wanted to find out why. I was curious. And so they told me that they were following a group of patients in the hospital who all had unusual opportunistic infections. And that was just before it was published in the MMWR, those first 5 patients. And then it was 7 patients, and then it was 9 patients. And they asked, one of the early theories about AIDS was that it was caused by CMV.
Oh.
And so they asked if I would examine all of their patients to see if anyone else had CMV retinitis. This particular patient had been so sick and was so obtunded that there was no possibility for him to have complained of vision loss. So I did examine all of their patients, and none of them had CMV retinitis, but they all had cotton wool spots, which as a first-year resident, I didn't recognize that they were cotton wool spots. They all had candidiasis as well. So I thought they had candida. I thought they had...
I see, because of the whitish. Yeah. Yeah. No, it's true. You wouldn't really think right, of that.
I was then shown that these changes were not candida. They were cotton wool spots. And just as we see in diabetic retinopathy or, any other microvasculopathy. So it was because of that experience that they asked me to keep examining their patients. So here I was a first-year resident being a consultant to the medical team. And then it was fascinating to me, and I just kept studying it from there on.
So and then it exploded, and it became a big topic in the news, but also in medicine. What was like the mood in Los Angeles at that time as the disease was becoming increasingly recognized?
A different reaction from different people. I remember being told by one person that I was wasting my time because everybody died, so why are you bothering? Other people were afraid to see the patients, so people knew that I would go and consult on patients, and so regulations were a lot different in those days. So I was invited to go to other hospitals to examine patients, without privileges.
Right.
And so, finally, when it became a big medical issue, people realized that it was interesting, and then a lot of other people got involved.
Yeah.
But, you were very generous in your introduction but at the same time that I was examining these people, Bill Freeman had seen patients in New York, and Doug Jabs was seeing people with HIV infection in Baltimore. And so we were all working on it at the same time. Alan Palestine at the National Eye Institute when he was there. But
by that time, did you all know each other, or were you sort of working independently and later came to know each other?
So Bill Freeman and I were fellows together here.
Right.
He had published a case report about the time that I published my first series. And I didn't meet Doug until after I was a faculty member at a meeting in Brazil. On the way to Brazil, I met him at the airport.
Oh, wow. You remember that? Meeting him, and you knew of him, that he was doing work in this.
I was introduced to him, I think, by Ron Smith, maybe.
Yeah.
While we were waiting for a connection to Brazil.
Yes.
Yeah.
Oh, that's great.
Wow. And then I guess you've had a passion for infections generally. You mentioned, it sounds like you were really busy with HIV/AIDS, CMV retinitis, and how did toxoplasmosis fit into that? Where did you find the time to start working in that area?
So that was my main project with Dr.
So that was...
And he offered to have me work with him on the animal model using non-human primates. I had become interested in toxoplasmosis, or I first became acquainted with it, not in medical school, but actually during residency. I remember distinctly, we would have breakfast rounds at the county hospital and go over the cases that had been seen over the weekend. And my first year resident, presented a case of toxoplasmosis, or what turned out to be toxoplasmosis, and he knew how to treat it, and I didn't. And from that point on, I decided I was going to learn about toxoplasmosis. So I was very happy to be offered the chance to work with Dr. O'Connor on toxoplasmosis.
Mm-hmm. Wow.
Yeah, I can see. I mean, that's a really formative early experience. And we all know of Dr. O'Connor's works. That must have been incredible at the time.
Mm-hmm.
Yeah.
To work with him.
And
how is it working with him? I got to meet him in my early years, but he was quite in his, he was retired and would come by. So I never got to directly work with him on research or clinically, but he really came into, to visit here until the very end. He was very sharp, but I'm interested to hear.
I really think that people consider him the leading authority on uveitis in the world. I showed a whole series of people, but people were very deferential to him, at meetings, asking his opinion about things. But working with him was wonderful. I finished my residency on June 30th, and I started fellowship July 1st. So I drove up here the night of the 30th.
Wow.
And Dr. O'Connor called me and said, "Would you like me to bring the papers to your apartment, to get you started?" And I said, "No, Dr. O'Connor, you don't have to do that. I'll come in early the next morning." And then when I finished, I finished and then I drove to Atlanta and he offered to do my dictations for me. And I said, "Oh, that's way too generous."
Wow.
I remember the night before the boards, he called and, wished us luck. And he said, "Now I want you to get a good night's sleep tonight and drink a glass of warm milk." And I thought, oh, sleep maybe, but not the warm milk. Like he was so supportive.
Oh.
Yeah. And then we hadn't actually finished the paper on the primate model. And so he actually, I think he was driving to Mexico because he had a house in Mexico.
Oh, wow.
I didn't know that.
And he actually stopped and helped me finish the paper in Los Angeles.
Oh, my goodness.
Yeah.
Incredible.
He was the best.
Yeah.
What a great mentor.
Sounds like it.
That really,
Very nice.
Yeah.
So when you were,
I have to say everybody was great.
Oh, yeah, but that's pretty extraordinary. I mean, that's going beyond.
Right.
It's really good to know that.
Yeah. Everyone was very supportive here.
When at UCLA, now it's really recognized, what you've set up in this world-class center for uveitis and ocular inflammatory disease. What was it like when you were starting there on faculty? Was there anything at all?
No. Most departments did not have anyone interested in uveitis. People would do it by default, but, were not really invested in the practice. And even when I was a fellow, there was very few centers. There was Ted Schlegel, there was Bob Newsonblatt at the NEI, and the Proctor Foundation, but there was really no organized uveitis teaching at UCLA.
Okay.
And so it was basically me. And so for years I did half cornea and half uveitis. But it got to the point where there was 5 of us doing grafts and nobody wanted to see the uveitis patients. So I just gradually went from being half and half to just seeing inflammatory disease. So that could include cornea. I still see people with herpetic eye disease and scleritis.
Yeah, I think that's...
Yeah, but I stopped doing grafts and really was not interested in seeing patients with corneal dystrophies and some of the other classic corneal problems.
So more recently, you have become interested in gun control and helping medical students who are exposed on some level to gun control. How did that come about? That seems very atypical for a uveitis specialist.
Unrelated to uveitis. I just thought it was my good civic duty to contribute to some of the groups that were working to reduce firearm violence. And I was a longtime donor to the Brady Center after Jim and Sarah Brady formed the center after he was shot when Ronald Reagan was shot. And because I was a long-term donor, I mean, I didn't have the money to make major contributions, but I was a consistent donor. Actually, they contacted me, and I came to know the president of Brady, Brown. And I remember after the Parkland shootings in Florida, a lot of the medical students at UCLA wanted to do something. So they had their own little March for Our Lives parade in Westwood. And, I was very involved in teaching, so I knew a lot of the students. I said, that's great. I appreciate your passion, but that's going to be forgotten before long. You really need product. And so one of the students actually did a project looking at all the ophthalmic injuries at the Level 1 Trauma Center at Harbor UCLA Medical Center. And it's, one person is blinded every month, year in, year out from gun violence. So it took a long time. We finally got that written up. It hasn't been published yet, but I think it points up the importance of morbidity as well as mortality. We hear a lot about how many people were killed at mass shootings, but actually the statistics are that for every person that dies from a firearm injury, 3 people survive. And some of them are paralyzed and some of them are blind and a lot of emotional trauma associated with that. So there's a big push to have physicians more involved, and that can start in medical school. So teaching medical students to counsel their patients about firearm safety in the home. Don't leave your loaded guns out for little kids to play with. And so about 6 years ago or so, we introduced instruction into the medical school curriculum. It started with just an hour presentation on the epidemiology of firearm violence and how one should counsel their patients. And as opposed to the few schools that were doing that, where they assessed the effectiveness of their training just with student surveys, we actually 6 months later assessed whether the same class would counsel a model patient on firearm safety, and only one student did.
Oh, wow.
So probably the same is true at other schools. So the dean's office actually allowed us to expand the training to 3 hours, and then we've done a lot of things to reintroduce the topic during the subsequent months. So whether it's in pediatrics or intimate partner violence instruction, and we actually got to the point where more than 50% of students were at least raising the subject.
That's really, that's a big
difference. And now about a quarter of medical schools have some student training about firearm violence. And it really needs to be incorporated into that social history taking. Do you wear your seatbelts? Do you drink too much sugary drinks? Safe sex? What, the whole list of issues. And firearm safety should be part of it.
And how does can you describe the clinical trial that involves this? There is something listed on UCLA's website about a clinical trial for medical students and gun safety.
I didn't know that that's on the website.
Yeah.
Oh, well, that's interesting. Yeah, what we did was in the transition year between UCLA revamped its curriculum. Just like a lot of schools, they've compressed the preclinical year. And so in that transition year, the last year of the old curriculum was the first year that we had the training session.
Okay.
And then the next year, it was just a part of the new curriculum. Both years, the last OSCE, the simulated patient encounter, we used the exact same scenario, which was a postpartum woman with depression, teenager in the house, unsecured guns. But the unsecured guns wasn't a part of the scenario that was revealed to the student unless they ask about it.
Right.
And so it was controlled, but not randomized, obviously. So it was 2 full classes with the same assessment.
I see.
And basically the same training.
Oh, wow.
Yeah.
Right. Impressive.
So.
No, I think that's a good, you have a deep interest in it, and it's incredibly important. Very important topic. And that's really great to see. And I think it's a great example of how you don't have to restrict what you do,
that's true.
If you, are interested in
other areas.
Yeah. It's a great example.
I don't know if enough of us are willing to take on those other interests. What do you think has changed the most in the practice of uveitis since you started?
Oh, so many things.
Hopefully all for the better.
All for the good, yes. I trained at a very interesting time when there was a lot of changes in ophthalmology. The first cases, cataract surgery cases that I did were intracaps. And within 1 year, we transitioned from intracaps to extracaps to phaco. So that was a big transition. YAG lasers became available. I had done some complicated cataract surgeries as a resident, but in those days, the teaching was that you left patients aphakic and you did big sector iridectomies so that they would have a keyhole pupil. And it didn't make a lot of sense, when I started seeing more patients because, a big peripheral iridectomy would serve the purpose just as well, and they'd still have a round pupil. So that was a big change. And when I was a fellow, people were not immunosuppressed unless they had very advanced disease because the concept was it was so dangerous to use immunomodulatory agents. So people had to have lost vision in one eye. They had to be below 20/40 in the best eye. But it's too late then.
Yeah.
Right. Yes.
And so the use of immunomodulatory agents and then the introduction of biologics has just completely changed how we manage cases.
Yeah.
And it's really shifted what people are concerned about. Back then, people were afraid that they were going to go blind, which many of them did. And now we wrote a piece about kids. What are their main concerns? Eye drops. They don't like their eye drops. It's the issue of a poor prognosis is much less of a concern than just, the annoyance of
so it's
having to be taken care of.
Yeah. You see a lot of children, right? And you have a whole body of work and contributions in pediatric uveitis. Were you always interested in taking care of children from the beginning, or how did that come about?
So I would see any patient that was referred to me. And when kids were sent to me, I remember not having a lot of experience. And I remember one mother asking me, how many kids have you seen? And so I was very honest. I hadn't seen a lot. And she said, well, I want you to refer me to somebody who's seen a lot of kids. And so I actually sent her to see Jim Rosenbaum in Oregon.
Yeah.
And I decided then that I was gonna learn how to kids.
Oh, wow.
And
it just takes that one experience. I'm very motivated to be your best.
And people, it's hard to take care of a little kid with inflammation, as you know. And so when it became known that I would see kids, I was seeing just a wide catchment area.
Mm-hmm.
I would see kids from San Diego and Hawaii, Las Vegas, Central. I think anyone north of, say, San Luis Obispo would be coming to the Proctor Foundation, but
it's still a huge area that you were taking care of.
But now, not so much now, because there's a lot more people who are willing and able to see kids. But that's really how it started.
Mm-hmm.
Yeah,
I saw lots of kids.
Mm-hmm.
I think that's great because, it makes a tremendous difference, of course, in any patient with uveitis, but especially in children, that you were there and able to see them right early on.
Yeah.
Yeah.
I think that's special about our subspecialty is that we get to see a wide range of people, including children.
Yeah.
We're moving into the future now, and sometimes people have dark views of what's coming around the corner, particularly with large language models, artificial intelligence. In incorporating those models and systems for uveitis, do you think it'll ultimately help us possibly increase access to care for people that live far away? Are uveitis specialists going to fall by the wayside and patients can get all their care from their MacBook or laptop?
Probably not. But I think that there are definitely opportunities to use artificial intelligence. I mentioned this morning, the fact that you can count anterior chamber cells with anterior segment OCT. One of the projects that I didn't show, but that can be automated now. You can use software to actually count the cells, and we get the same results as when all those dots were counted by hand on the images. So that will definitely improve monitoring of patients. And another project, I don't know that I mentioned it this morning, but what we would like to find is a biomarker for response to or if there is a response to anti-parasitic agents in people with toxoplasmosis, because we don't really know whether the drugs are doing anything in the self-limited disease in an immunocompetent patient. So we have a faculty member who's an AI researcher, not an ophthalmologist, and what we're hoping to do is to see if we can find a signal on images that corresponds to healing. And then we would be able to look and see whether healing occurs sooner in people that are on treatment. And, there's so many amazing things that can be done with artificial intelligence. The classic situation that everybody talks about is it says whether you're a man or a woman looking at a fundus image.
Yeah, I've read that it can tell.
Impressive.
Yeah.
So just how it does it, I'm not sure. But we're hoping that just with a large sampling of cases, we'll be able to identify a point that is a marker of healing and see if we can accelerate healing with drug therapy.
Yeah.
So, I do think there's some good opportunities. What I hope doesn't happen is people ask, ChatGPT what they should do for their uveitis, because there is a lot of misinformation out there. One of our former fellows did a study looking at everything on TikTok that he could find that mentions uveitis. And it was shocking, some of the things that were said, or people's ideas, or people selling, probably ineffective treatment, or advocating for treatment that don't work. So that would be a downside of it.
Yeah, I think there's always going to be ups and downs, but I think we have to be ready to, not just, I think we have to acknowledge that it is here to stay and will be part of our profession. So hopefully we can, as you said, utilize it to our benefit in areas where it might be an advantage or help, hopefully.
Yeah, absolutely.
But I agree with you. You've done a lot of work on outcomes also, and your work in looking at anterior segment cell objectively, I do think is very, very important. And I think points to the, fact that we have subjective outcomes right now. And, do you think that's limited our ability to do studies, to have more effective treatments? How do you think that's affected things?
It definitely has affected things. The FDA for a long time required a 2-step improvement in anterior chamber cells as a reliable indicator of improvement. But as I said this morning, a lot happens within one of those grades. We see a lot of people with 1+ cells, but there can be a lot of change in the concentration of cells from 10 cells to 6 cells within that 1+ grade. And so that's going to be one advantage, the precision that we get from being able to tell whether it goes from 10 to 6 cells per some area. But we won't be able to use that until we can say that that amount of change truly is clinically important.
Right.
And so that's where the validation issue comes in. And those are hard studies to do. They're long-term studies unless you've got a reliable marker, a surrogate marker for the outcome you're thinking about. Cells or automated counting of cells in the anterior chamber is clearly the farthest along in having an objective measure. Some of the others, there's some evidence that the vitreous signal, in fact, didn't Edmund Choi do a project with you on that with the FAST data? Retinal vasculitis is going to be very hard to objectify. Is it how much of the total length of the vessels is inflamed, or is it the location of the vessels or the size of the vessels? And so there's a lot of work to be done, and those are hard studies to do.
Yeah, I agree.
Same for choroidal inflammation.
Yes.
We routinely don't necessarily image the choroid in its entirety. We don't frequently perform ICG angiography. FAF only gets, to maybe some features of inflammation. So there's a lot left out. I don't think we know what we're missing, possibly. We're coming to the end of our chat here. If you were in an elevator with a first-year ophthalmology resident, what would be your elevator pitch for uveitis to that resident?
That would be hard because everyone hates uveitis residency.
Why do you think that is?
I think they're difficult problems. They take a lot of work. In career planning, it's not a specialty where people are going to make a lot of money. It's unfortunate that has to drive people's decision making. But I like to think that there are people out there like you guys who actually are interested enough to want to take the good with the bad, the amount of work that you have to do. So,
I think we have to keep on. I mean, I think it has so many amazing things as a field, but I think we have to look out for the future, because I agree with you. I think, it is challenging, and in many ways people may be deterred, but there's so many amazing aspects, which you've talked about today. I mean, look at your career and what you've done and the impact that the work can have and the air can have, it's huge, right? And so I think we have to, it really is.
Right. Literally on the front lines of new diseases, which I think we're coming to recognize can still happen even today. There can be brand new diseases that we would have never thought about. Yeah. So
and diseases are changing.
Mm-hmm.
Yes.
We talked about coccidioidomycosis, which is becoming much more prevalent.
Yeah.
At least in the southwestern United States, but extending north. And one thing we haven't talked about at all is the inflammatory disease that occurs with some of the new cancer drugs.
Yes. Yeah, you're right. I think
we had no idea.
That wasn't there before.
Right.
Yeah.
So I guess we always have to be on the lookout. I think with gene therapy, induced inflammation.
Right.
More reasons to go into the field.
Yeah.
I don't think it's going away. I don't think eye inflammation is going away anytime soon.
And there are people that talk about expanding at least the pitch, as you said, to say that inflammatory disease, rather than just uveitis, inflammatory disease potentially covers a lot of things, even macular degeneration, diabetic retinopathy.
Yeah.
That there is an inflammatory component to it.
Yep, there is. Yeah.
Yeah, we'll see. I guess that's it. Yeah, it's exciting.
Yeah.
Maybe there are, the more we understand about these conditions, we may see that there are ties, right, to the immune system. I think that's the case, likely.
What's your, in closing, what's a current project that you're trying to wrap up before you send it to a journal?
I would like to finish up our work on host-parasite interactions amongst people with toxoplasmosis. I think that's a fascinating area. And as I said, I'm not smart enough to solve it, but I think I know who can.
Okay.
And so I would like to continue looking into that.
Okay.
The data that I presented this morning, we're close to submitting that. We're trying to finish up our description of the control group, actually. And we have another whole bank of specimens where there's some refinements in the both from the parasite side and the host immunogenetic side that are being done, that we can actually expand some of that work. But that really interests me is why do some people get eye infections and other people don't?
Right.
And it's this constant war between host and pathogen.
Yeah.
Yeah.
So I think that's an interesting area to pursue.
I think that's our elevator pitch. That
it's a good one.
There's still a lot to keep people interested and passionate. I think chatting with you today, it's really easy to see how passionate you are about these areas and issues and problems in uveitis. And so I think that would be really special for residents to hear that comes across clearly. So thank you for spending time with us.
Yeah, it's my pleasure. Thank you. Thank you for talking to me.
It was a pleasure to have you.
So this concludes our first podcast.